quality management lecture series. This air quality management lecture series is jointly organized by Department of Civil Engineering, IIT Madras, and CEPHA Network, Clean Environment for Planetary Health in Asia Network. So the whole idea is to having 5 components: knowledge exchange, engagement of citizen, networking, empowerment, and innovative solution. So we try to look at it, each of these objectives, try to engage researchers, citizens, policymakers, health sector, and industrial and other stakeholders to understand and exchange the various aspects of air quality management. And we also try to identify what works in one particular place in terms of technology, and then try to see that whether it same can be applicable in other places, and what are the knowledge gaps, key challenges, barriers, enablers. So we'll try to look at those aspects and strengthen the national and international cooperations, build the capacity and capability, and widen the participation across the sector and socioeconomic groups in addressing this air quality management. Of course, we also try to work closely with all the collaborators in terms of generating the funds to sustain these activities. So we started this CEPHA activities about more than 2.5 years back with various initiatives. We have a newsletters, quarterly newsletters, which attracts younger minds to express their views on air quality management and other environmental issues. We have conducted several panel discussions to address various environmental aspects. Then we also looked into the various documentation, for example, how to influence the younger minds with videos, have a small stories, and also workshops and symposium, several community activities, including the paintings and creative drawings. So all those aspects has been carried out in order to engage every component of the society. And we also look forward to joint research cooperations and in terms of publications. Recently, we started about a month back, we started a Air Quality Management Association. It's a first of its kind in India, basically to enhance the understanding of the science behind air quality and issues that required to address the air quality management and promoting knowledge on clean air and understanding the various working practices. And our director and the former chairman, Tamilnadu Pollution Control Board, has inaugurated the Air Quality Management Association. So this is about our upcoming conference in the month of December. This week started in 2016 successfully. Now we are running the 7th year conference, Indian International Conference on Air Quality Management, which discusses the various issues of measurement, modeling, and health risk and public policy. And this will going to this year conference will planned from 29th November to 1st December 2022. And we also planning to have winter school on social apportionment, modeling, and health risk assessment. And I'm sure I'm requesting maybe Professor Kalpana to be free on one of the slot to share her knowledge and experience to the younger minds. Coming to the air quality management lecture series, we started October 2020. This is the 22nd lecture. Basically, the idea is to provide a forum for the younger researchers, scientists, and engineers and educators to exchange their ideas and their views on air quality management, and also enhance their understanding on air quality management, to discuss about recent technologies that are available for air quality management, the various issues, and particularly the health risk aspect, which Professor Kalpana is experienced and having a vast contribution to not only to the Indian context, maybe in the global level, and also to explore the collaboration with the stakeholders. So these are all our past air quality management lecture series speakers. And we have all the eminent speakers, and we are very happy and honored to have Professor Kalpana Balakrishnan for this month lecture. So the last lecture was given by Dr. Srinivasulu, a senior IAS officer and also a member secretary of Karnataka State Pollution Control Board, Government of Karnataka. So now this lecture, so we have with us Professor Kalpana Balakrishnan, and I request Lakshmi Pradeep to introduce the speaker.
Good afternoon, everyone. Welcome to the Air Quality Management Lecture Series for the month of July. It is my pleasure to introduce the speaker of today's lecture, Professor Kalpana Balakrishnan, Dean, Research and Director, WHO Collaborating Center for Occupational and Environmental Health, ICMR, Center for Advanced Research on Air Quality, Climate and Health, Sri Ramachandra Institute for Higher Education and Research, Chennai. Dr. Kalpana Balakrishnan obtained her undergraduate degree from the All India Institute of Medical Sciences, New Delhi, and subsequently her doctoral and postdoctoral training at the Johns Hopkins University, USA. She is a leading global environmental health scientist in India, spearheading research and academic efforts in the areas of health effects of air pollution and chemical risk assessment. In 2020 and 2021, she was ranked among the top 2% of scientists in the field of general and internal medicine in an independent study conducted by Stanford University. She has contributed to several national and international technical assessments concerned with air quality, including the Global Burden of Disease and Comparative Risk Assessment, the IARC monographs, the Global Energy Assessments, the World Health Organization Air Quality Guidelines, and the India State Level Burden of Disease Initiative. She is also a Fellow of the National Academy of Medical Sciences, India. She currently serves as a member of the National Steering Committee on Air Pollution-related issues for health effects for the Ministry of Health, Government of India, and the Indian Council for Medical Research-led National Task Force for the Assessment of Impact of Initiative to Promote Clean Household Energy. She is a recipient of many awards, including the Clarivate India Research Excellence Citation Award, the Public Health Foundation of India Award for Outstanding Scientist in Public Health, the Hari Om Ashram Trust Award for Outstanding Scientists administered by the University Grants Commission, Government of India, the Outstanding Woman Scientist Award of the Government of Tamilnadu, and the Award for Excellence in Environmental Health Research administered by Harvard Medical International. Today in the lecture, Dr. Kalpana Balakrishnan will be talking on the topic Catalyzing Air Quality Concerns to Address the Health Burden from Ambient and Household Air Pollution, Experience from Field Studies in India. The talk will cover ongoing and planned initiatives that provide unique opportunities to strengthen the evidence base and prioritize air quality actions to create seamless breathing spaces. With great pleasure, we welcome you, ma'am, and over to you.
Thank you, Lakshmi. It's a great pleasure and honor to respond to the invitation of Dr. Shiva and all of you colleagues at IIT Chennai, a long-term collaborator of ours. I've personally been involved in collaborations with Dr. Shiva for almost 20 years now. So it's a great privilege and pleasure to be part of this newly launched series on air quality management lectures to sort of catalyze this action. If with the permission of the organizers, should I start sharing my presentation and screen?
Yeah, please, Professor Kalpana, you can please share that.
It's trying to project from a different computer. Just one second. Just give me one moment. I'm just reconnecting. Yeah.
No issue. Please take time.
Okay. Yeah, just one second. I'm trying to use two different computers so that the projection and the camera will be easier. Okay. Are you able to see my slide now?
Yes, you can able to see the slide.
All right. Sarah, is it just me?
Maybe one of the screen, you can close both camera and audio so that it will not echo.
I did.
Yes. And now you can unmute from the other computer, the one which you are using.
Yes.
Now we can hear you. Yes,
All
right.
right. No matter how many times we try, I think, there will always be one glitch that we would not have mastered the last time we did this. Yeah. Well, thank you again for all the participants who have kindly joined. In the next 45 minutes or so, I thought I would share some of our, team's experience in, engaging in a lot of field epidemiological studies, essentially to assess the health effects of air pollution and do so in a way that air pollution would be considered amongst the many risk factors that impact the same health condition that are normally targets of public health action. So many of us are quite familiar when we talk about public health that we want to be looking at vaccines for us to protect ourselves against infectious disease, diet to protect ourselves against non-communicable disease, exercise to protect ourselves against diabetes or cardiovascular disease. But we don't quite think of air pollution in the same breath as something that we need to intervene on in order to extend our life expectancy, prevent, premature mortality from some of the same disease conditions for which, good public health actions are already available. But air pollution is still not been able to sort of, gain the same amount of priority, largely speaking. Of course, the best way that we are already moving towards that direction is the implementation of the National Ambient Air Quality Standards, because the standards are primarily health-based. So whenever efforts are undertaken to move towards the National Ambient Air Quality Standards or the WHO Air Quality Guideline values, we are automatically making strides towards health. But clearly, many of you, this is not new information, already recognize that we're very far away from even the National Ambient Air Quality Attainment Standards in most parts of the country, and much in excess of the WHO Air Quality Guidelines. So our goal in India should be sort of really look at what can we do to address this important public health concern that, by virtue of its origin, because it's the air is the medium that is impacted by this particular risk factor, you cannot have compartmentalized approaches to deal with this risk factor. If you're looking at rural air, obviously it's going to spill over into urban air. If you are looking at outdoor air, obviously it's going to spill over into indoor air, and vice versa. So as far as protecting ourselves from anything that is airborne, that is harmful, we have to look at a paradigm of being able to create seamless breathing spaces that are healthy and that sort of extend not only in all the microenvironments that we spend our time on, but also create these spaces throughout the lifetime. It is not sufficient that if you're during your childhood years, you're in a healthy place and then you move to a dirty place, that your health will be not compromised. You have to sort of really maintain these healthy spaces throughout your lifetime. And these pictures that I have shown in the very first slide just underscore the reality that all of us in India experience on a daily basis. This is not new to us. Our roads are congested, our roads are dusty. Many power plants, still are in excess of the emissions, requirements. But this urban imagery is very familiar to us. The rural imagery is also familiar to us, but we don't quite think of air pollution in the same breath in the rural areas as we do in the urban areas. Somehow, as soon as we say air pollution, especially to many of you young students, you would probably most likely have read about urban air pollution, industrial air pollution, traffic related air pollution, even unorganized industry related emissions, but not quite think about the use of dirty and solid biomass or other types of fuels that end up exposing women and children over a lifetime in our rural and the poorest amongst our homes. So the goal of my talk today is to share some of our research experiences almost over a 25-year period in collaboration with many eminent institutions in the country, including IIT Chennai, about how can we start creating the process of seamless, healthy breathing spaces in India. Where are we now? And where should we be headed in terms of research priorities in the future? So if you look at, why is air pollution such a bad thing for our health? We didn't think that air pollution was actually responsible for health effects that can impact so many target organ systems in the body. If you look at what the current evidence stands for, according to the European Respiratory Society and the American Thoracic Society, that have led the efforts in sort of putting together the consolidated evidence that forms the basis of both the WHO air quality guidelines as well as many national standards. What constitutes an adverse health effect of air pollution is all these conditions that I have listed. The earliest amongst those that we recognize was respiratory disease mortality and respiratory disease morbidity. That is intuitive. Lungs inhale, you can suffer from respiratory disease morbidity, which may result in respiratory disease mortality. But many years ago, as much as 40 years ago, the cardiovascular disease mortality and the cardiovascular disease morbidity already was beginning to take evidence. That was followed by, cancers of the lung, pneumonia, stroke, and more recently, diabetes, premature birth, and many adverse pregnancy outcomes. So what we are now at is a spectrum of air pollution related diseases for which we have some very strong evidence for all those above the dotted line that I have listed here. Many cardiovascular conditions, lung cancer, many respiratory conditions, including acute respiratory infections, asthma, pneumonia, COPD, and many biomarkers of early cardiovascular disease as well as cardiovascular mortality. But the ones that are listed below, the evidence is emerging and still being consolidated. In some cases, they are stronger than the others, but all these entire spectrum of air pollution related diseases that are attributable to air pollution exposures in the urban and the rural environment formed the basis for the most recent version of what are called as the WHO air quality guidelines. The WHO air quality guidelines that I have been very privileged to be a part of, provides extensive scientific evidence and identifies the levels of air quality, what we are all familiar with. What should be the level of criteria air pollutants, PM 2.5, NOx, SOx, ozone, carbon monoxide, and so forth, that would be necessary to protect public health worldwide. And one of the myths that we seem to be harboring, despite the dissemination of the WHO air quality guidelines for nearly 3 decades, is that these guidelines are only applicable in the urban ambient environment. No, these are guidelines that are expected to be applicable in all microenvironments, perhaps with the exception of the occupational environment, mainly because the occupational population is considered to be relatively healthy, and therefore, standards in the occupational settings have always been higher than the other microenvironmental standards. We don't have specific indoor air quality standards for PM 2.5 as part of the WHO air quality guidelines, but implied in the guidelines are that these guidelines are applicable everywhere that the general population spends their time in. And therefore, you have short-term guidelines, 24-hour guidelines, as well as annual guidelines. And these guidelines are the best instrument for us to design effective measures to achieve reduction of air pollution. And this is a very important thing to bear in mind. A lot of times, including, many environmental impact assessment and other things that are required, as part of our, environmental management practices, often, task even industries, or for that matter, researchers with the very difficult target of sort of looking at, can you demonstrate health effects from this particular level of air pollution? Can you demonstrate benefits of health from a particular air quality management initiative? Unfortunately, it is not very easy to do that. Because documenting health effects of any one pollution in any one population is a decade-long exercise, or often several decade-long exercise. And for many countries like ours in India, where the capacities to do that is very limited, it's important to remember that the WHO air quality guidelines serves as the best benchmark for air quality management. Anytime we move towards the WHO air quality guideline values, it means that automatically we are moving towards improved health. So what exactly are the WHO air quality guideline values? So you will see that in the last column, what it says as AQG level, or WHO air quality guideline level, it provides an annual average concentration for criteria air pollutants, PM 2.5, ozone, NOx, SOx, and CO, as well as it provides an interim target guideline level value, mainly because the air quality guideline level that has been listed there, as you will recognize, is quite impractical for developing countries to achieve in the near term. So if we are wanting to benchmark our air quality management initiatives against a health benchmark, could we look at the highest interim target guideline value? Say, for example, for PM 2.5, it stands at 35 micrograms per meter cube of annual average. And many of you who are familiar with the National Ambient Air Quality Standard for PM 2.5 will recognize that our national standard very closely mirrors the WHO interim target 1 guideline value, and the goal would be to sort of really march towards interim target 2, 3, and then eventually 4, and finally to the air quality guideline level. The interim target 4 was the previous WHO air quality guideline value in 2006 when we updated the guidelines. In 2021, we have reduced this guideline level further for most pollutants based on evidence that we are finding health effects at lower and even lower concentrations. So this is something that is an ongoing process for all air quality management initiatives throughout the world, including in India, where we are looking at improving health by reducing the exposures down to the levels what that WHO recommends. And basically the interim targets are guide the reduction efforts that will be required for the achievement of the air quality guideline levels. So if you look at, where do we in India stand with respect to air quality guidelines in India? Unfortunately, this is not a pretty picture. Many of us have seen this in media and feel quite bad about it. Those of us who have been working in the air quality management field for such a long time don't like India's cities being listed in the worst polluted cities in the world, but that is a reality, unfortunately. This is a somewhat dated slide in 2018, but the picture is not very different. Some of the cities have gone up or down a little bit, but cities like Ghaziabad and Noida and Kanpur and Mandi Gobindgarh have remained the list for a very long time. We don't see too many of the southern Indian cities. Fortunately, the sea comes to our rescue. And of course, a very good job by the industry, ecosystem, as well as the regulatory ecosystem in Tamil Nadu, especially, wherein we have been able to make quite a bit of efforts towards achieving lower concentrations of many of these pollutants. And these pictures, again, for those of you students, should be a reminder that we are familiar with the industrial sources. We are familiar with the targets, traffic sources. We are familiar with the unorganized industry or the small scale industry sources, including the brick kiln industry and so forth. But we have to very much keep in mind that agricultural crop residue burning and the use of dirty domestic solid fuels for household cooking and resuspension of dust continues to form a very, very important source of many criteria air pollutant exposures. And when you look at these pictures, these are just a sordid reminder that rural homes, which we never think about when we talk about air quality management, end up exposing people, young children, pregnant women, and even men and older women over a lifetime. So this exposure starts all the way. You can see that young child there, or for that matter, the pregnant woman, right from in utero exposures. And you have to recognize that some of these air quality management initiatives are not only needed for the air pollution exposures that they provide, but also the overall quality of life. Look at the woman who is actually, processing dung cakes in order to provide fuel for her stove, or the woman who is collecting wood, from the forest to sort of really, so this is a double, whammy, time poverty as well as energy poverty and air pollution insults all combined in one that beg for being addressed as part of the air quality management initiative. Because of this, ubiquity of sources and their ubiquity in both urban and rural areas, shown here is a picture of the status across various states in 2001. The black bar represents urban exposures and the light bar represents rural exposures, specifically for annual average PM 2.5. The red solid line represents national ambient air quality standards. You recall I mentioned the WHO interim target guideline 1 of 35 micrograms. That is very close to the national ambient air quality standards, the red dotted line, and then you have the blue dotted line, that is the interim target guideline value 1, 2, and 3 progressively. I have not shown the line for 5 micrograms per meter cube for PM 2.5, which is the newest WHO air quality guideline level. If this was the situation in 2000, unfortunately, even when we repeated this exercise in 2015, this is the change in the exposure to PM 2.5 between 2000 and 2015 based on aerosol optical depth or satellite data. And the maximum change, we have gained some, there is no question about it. The maximum level that we have gained in any state for that matter is anywhere between 10 to 15 micrograms per meter cube. So you can imagine if the annual average is around for the country as a whole is somewhere of the order of 70 or 80 micrograms per meter cube annual average PM 2.5, gaining 10 or 15 is not really helping us even move towards the national ambient air quality standard of 40 micrograms per meter cube. Forget about the WHO guideline value. So given this widespread and continuing exposures to air pollution over more than 3 decades since the industrialization and the development has been happening at a hectic pace, you can expect that the health burden attributable to air pollution in India is very, very significant. So if you can look at what do we know now about the exposures to both ambient and household air pollution, here is some of the latest results from what we call as the India State Level Disease Burden Initiative. This is a project, this is a component of the Global Burden of Disease Initiative. And here we have various states graded with respect to the population weighted exposure. You can see and feel quite happy that Tamilnadu is, along with Kerala and all our southern neighbors are at the lowest end of the spectrum, both on account of, some geographical conditions that favor greater dispersion, but also in a great measure due to tighter and much regulated emissions control and much lower population densities compared to Uttar Pradesh or Madhya Pradesh or Odisha, as the case may be. Another important reason why the exposures to ambient air pollution is higher is also because the proportion relying on solid fuels is also amongst the lowest in the southern states. The use of solid fuels, as I mentioned, contribute to emissions within the house as well as outside the house. So therefore, the state level exposures now we understand quite well, and clearly the priority states are very obvious where we have to look at prioritizing the air quality management initiatives. And this may come as a surprise, but nearly 17.5% of all deaths in India were attributed to air pollution. Clearly, it means that if you reduce air pollution exposures, you would make a difference in the premature deaths in India is the underscoring message. Many of us who have been closely involved with this actual estimate of health burden attributable to air pollution argue about the numbers. Is it really 1.67 million? With equal contributions from ambient and household air pollution, there are some uncertainties around these estimations, but it will suffice for us to understand that the health burden attributable to India in air pollution in India is amongst the highest compared to many other risk factors, so much so that not only do we estimate up to 2 years of life expectancy loss attributable to air pollution in India, which is at the highest end of the spectrum compared to the rest of the world and developed countries such as USA and Western Europe. But more importantly, very classical public health risk factor. If you talk about public health, the first risk factor that comes to mind is smoking, active tobacco smoking. Everybody wants to quit smoking, and that is a message that we have taken, in terms of public health messaging, starting from our theaters, starting from our billboards. Every advertisement carries the word smoking is injurious to health. If we start putting the board saying air pollution exposures is injurious to health, where in India will you go and live? We don't have a place to live, but yet the fact is, air pollution health burden, air pollution impacts the same diseases as does tobacco. because what tobacco releases is products of incomplete combustion. What air pollution exposures does is also products of incomplete combustion, and they, through the inflammatory pathways and the other mechanistic pathways, impact lower respiratory infection, chronic obstructive pulmonary disease, ischemic heart disease, stroke, diabetes, lung cancer, and cataract. This was done in 2019 before birth weight was included in the state level disease burden initiative in India. But we now recognize that air pollution as a risk factor must be fought in the same war footing as tobacco. One of the distinguishing factors between tobacco and air pollution is the number of tobacco users is small, but the individual risk is much greater. But in air pollution, the individual risk is much smaller, but the number of people exposed to air pollution is much, much, much higher. And therefore, intervening on air pollution benefits a lot of people, but much more than what intervening on smoking would do. But that's where smoking was some years ago. It's because we intervened on smoking is why the air pollution burden attributable to tobacco is smaller now. But we urgently need to intervene on air pollution is the bottom line message that we have to understand. We shouldn't be sort of really spending time arguing about the uncertainty surrounding these estimates, but unequivocally it has been established that the burden attributable to air pollution exposures to India requires immediate and imminent attention. So let me just take you over in terms of how if policymakers are asking our research community, our student community, and our citizen community to sort of really why do I have to act on air pollution? We need to be mindful of the evidence that is already available. Researchers have to provide a different level of evidence. Citizens have to absorb this evidence and sort of really raise the requests going for intervention, and policymakers therefore can be much more responsive in sort of prioritizing resources, and more importantly, understanding the evidence allows us, as Dr. Shiva was mentioning, one of the goals for this new collaboration and the air quality management initiative is we can't win this war alone. We need local, national, and global collaborations on health research in order to play a strategic role in facilitating clean air actions. Clean air actions is the purview of Ministry of Environment. It's not the purview of Ministry of Health. But Ministry of Health and the health sector needs to increase the demand for intervention because it is a health issue that is outside the purview of the health sector as far as actions are concerned. So therefore, this underscoring element that Dr. Shiva was mentioning, intersectoral collaboration. Nowhere is this the case more than air pollution. Not only intersectoral, intergovernmental, as far as climate change is concerned, and interstate and intercountry also sometimes, because air pollution does not know any boundaries. It is going to affect more than the people who are responsible for generating it, and therefore we have to be very mindful of the imminent need in India to consolidate this evidence and inform the policy. Let me just spend the next 5 minutes taking you over very quickly in fact all the studies that I'm showing are all published papers. You can find them. You can contact us if you need full copies of these articles. Many of them have been led by our group. But it is very important to recognize, often this question is asked, are we importing evidence from outside developed countries? And our people are somehow immune to air pollution. We have more natural immunity. When we are looking at cholesterol drugs, when we are looking at heart attack risks, we look at primarily studies that were originally conducted in developed countries, and even without waiting for evidence from developing countries, which is now available for many of the treatment regimens, we are quite quick to jump on to those without demanding for local evidence wherever the evidence is good. But when it happens in the air pollution arena, or for that matter in all public health, where the individual risk may be somewhat smaller, but the population risk is much, much greater, it's very important to recognize that health effects studies conducted in India are continuing to contribute to the evidence. And now, after 20 years since we actually started this work, we are quite proud to say that there is a huge number of studies available from India, including in prospective cohorts, longitudinal studies. So where have we made the maximum amount of gains? First of all, in order to measure health effects in any study, you need to have a way of assessing exposures. Just relying on ambient air quality monitors may often not provide you the answer, because not all over India you have ambient air quality monitors. The nearest available ambient air quality monitor may be hundreds of kilometers away depending on where you are, and your exposure throughout the day may not be captured by this ambient air quality monitor sitting on a rooftop. It provides a global indicator of the entire community level exposures, but it doesn't tell you about what your individual exposure looks like. So personal exposure monitoring is a very important requirement for health studies. And this is an exercise that we have made great strides on. We have now developed, validated, and deployed field instrumentation to capture exposure heterogeneity in both rural and urban microenvironments using a variety of gadgets. Perhaps, Dr. Shiva, your students in IIT and many other IITs, you are very familiar with the BAMs, the E-BAMs, as well as the low-cost sensors that are also, shown here. But many of these are, personal monitoring devices that even the most, difficult and, hard to convince age groups like elderly women, uneducated women, rural women, pregnant women. These gadgets have been developed to a point where they are lightweight, unobtrusive, and people are actually willing to wear them during the course of these cohort studies. And we have conducted now numerous studies in which these devices have really been able to provide some very good answers for what the personal exposures look like. And not only in rural women, but school going children, in urban children, in rural children, we have been able to conduct rural ambient air quality monitoring, as well as you see the whole host of low-cost sensors, many of whom involve the entrepreneurial capacities of the IITs, including IIT Chennai, IIT Delhi, IIT Kanpur, and so forth. So from short-term to long-term monitoring, we have been able to do with these gadgets, in addition to the ambient air quality monitoring that is done routinely for regulatory purposes, so much so that we have been able to now integrate satellite data, ambient air quality monitoring data, personal exposure monitoring data, microenvironmental monitoring data, all to feed into various types of health studies. So on the because we have gotten so good in monitoring exposures, it has now been possible for us to use this exposure information in exposure response assessments that are addressing health impacts of national relevance in prospective rural urban cohorts, which means that we are able to monitor many risk factors in these populations so that we can address air pollution. So for example, if you are looking at pneumonia, if you are looking at low birth weight, it is not sufficient if you monitor air pollution alone in these populations. You have to be able to assess nutrition. You have to be able to assess other infectious diseases, other parameters that are often called in cohort studies as covariates that vary at the same time as air pollution, before you can sort of tease out the air pollution attributable response. And that requires that we have to prospectively monitor them, not retrospectively study them. So we have been able to look at addressing many health impacts of national relevance in rural urban cohorts, and this includes child health, adolescent health, maternal health, and adult health, as illustrated here. So if you can look at, I think there is some background noise somewhere.
This station is Kalpana.
Can we look at muting? Yeah, okay. All right. So we can look at, I'm just listing some of the cohort studies that have been published both by our group as well as, several other important research groups in country. These are all studies that have been conducted. And for those of you in Chennai, it'll please you to know that many of these, Tamilnadu has led the brigade in terms of sort of lots of air pollution related cohort studies. And this is a study called the Tamilnadu Air Pollution and Health Effects Study, the publications that establish the relationship between air pollution exposures and birth weight, as well as child acute respiratory infections, adult lung function, and chronic respiratory symptoms. And we monitored nearly 1,200 pregnant women and their index children from 110 villages in Tiruvallur district, as well as 10 municipal zones of Chennai district for a period of 3 years, basically pregnancy and 2 years of age, in order to establish this relationship. The next study is also in the Tiruvallur and Kanjipuram districts, wherein nearly 8,000 participants were monitored for cardiovascular risk factors in Tamil Nadu by our cardiology department, and we used satellite-based ambient PM 2.5 as well as microenvironmental PM 2.5 measures to look at relationships with blood pressure, insulin resistance, as well as endovascular outcomes in this particular cohort called the PERSIS cohort. Yet another cohort that we have been involved with is in Andhra Pradesh, wherein we have been able to look at, again, about 3,000 participants that were enrolled in a nutritional study cohort, in which we actually use land use based regression models for ambient PM 2.5, along with microenvironmental monitoring and personal exposure monitoring, to look at exposure response relationships for biomarkers of cardiovascular disease, carotid intermediate thickness, as well as many other indices that are listed there. And here is an example from another study that has been conducted by Public Health Foundation of India in Delhi, in the CARS cohort, where they have looked at 1 kilometer by 1 kilometer satellite-based ambient PM 2.5 concentrations in a prospective, cardiovascular disease cohort, where they looked at incident blood pressure as well as PM 2.5 concentrations, and this is also this was already also published in in circulation in 2020. Sorry, in hypertension in 2020. And there are now an increasing bunch of health studies that are using satellite-based methods. There are still some uncertainties in using satellite-based methods, but they are getting better and better. We now have relationships for infant mortality, cardiovascular health, anemia, child development, and so forth. So no longer is this argument of not enough health studies in India, not enough exposures assessments that are needed in order to sort of look at the uncertainties of relying on ambient air quality data or satellite data. None of this is justified any longer, because we now have a very rich evidence from research work done in India. And more importantly, we have now built in Srihar, by virtue of ICMR funding, huge environmental biomonitoring capacities, where we can look at biorepositories of hair, blood samples, dry blood spots from adults, from children, urine, and many other biological media, where we can look at many epigenetic questions, as well as gene environment interact questions, as well as early clinical markers oxidative stress markers, exposure biomarkers, as well as biomarkers of susceptibility that are listed here. So let me spend now the next 5 minutes. We are coming up on time here. On what can we do to inform air quality actions here. As we know, the National Clean Air Program has been launched already. That has involved inputs of many IIT colleagues and many of us health researchers. And the National Clean Air Program identifies many sectoral interventions under NCAP, intervening on transportation with e-mobility, indoor air pollution, including clean cooking, as I mentioned, agricultural emissions, power sector emissions, and so forth. So let me just give you one example of how our group and all the research we are collectively doing is looking at one of these sources, especially household sources. Now there is available more than 5 studies. If you can look at the yellow bar, in terms of percent contribution towards ambient PM 2.5 from each one of these sectors, several studies have now identified that household air pollution from the domestic use of residential cook fuels is one of the largest contributors to ambient 2.5 in India. And the burden attributable to ambient PM 2.5 from the household sector is much higher compared to the ambient 2.5 from other sources, and therefore mitigating household sources could be the lowest hanging fruit for air quality actions. Recently, in 2019, there was a very seminal paper that Dr. Sagnik Day and Dr. Chowdhury led, wherein they showed through chemical transport and satellite-based modeling exercises, primarily through dispersion models, wherein it was shown that if we were to eliminate all household reliance on solid fuel cooking needs, we would be within the national ambient air quality standards in almost all the districts in India, with the exception of a very few in the Indo-Gangetic belt. Even that would be within manageable, much closer to the ambient air quality guidelines. But virtually all of the country can be expected to come within the national ambient air quality standards just by intervening on this one source. And the Indian government, as many of you know, has already moved one step in that direction, primarily through information from global pioneers of this particular exercise that we have had the privilege of collaborating. Now 99% of households in India through the PMUI program have access to LPG, in which more than 80 million households have been provided with an LPG gas connection. But unfortunately, without sort of really going through this complicated exercise, it is very, very important to recognize that even though you may get a connection, many households are not able to sort of get to use LPG. On the average, it takes about 10 years for anybody with an LPG connection to transition from biomass, which is the blue bar, to the gray bar, which is almost exclusive LPG use in most of the states where LPG use is very, very minimal. As you already recognize, Tamilnadu and Andhra Pradesh are not the examples where we have to look for LPG use. If you look at Bihar, Jharkhand, Madhya Pradesh and West Bengal, LPG use is still very, very minimal in the rural areas, and we don't want to be waiting for another 10 years to get the benefits to their pregnant women. So what are we doing? We are looking at explaining many important short-term gains. We can't give everybody free LPG tomorrow. That's not possible. So can we look at some target groups? Can we, if we give pregnant women for a period of 6 months, will it benefit their health? What would it take? Do we have to give them free LPG, or can we give them, some subsidy? Can we look at, if you use, we will give you more subsidy, conditional cash transfer. If can we look at providing them free LPG and really seeing if their exposure reduces and so forth. And I recognize that my time is sort of coming up for wrapping it up, but just want to point you to these two studies. One is the Implementation Science Network project that we have implemented in Maharashtra, wherein, please look at the right, bar, of graphs. So basically, the green bar is any biomass use. The red dots are any, LPG, sort of exclusive LPG use, and the blue is any LPG use. And it is very clear that when you just do the core intervention, which we did, just we gave them a connection and just said, whatever you want, please use LPG. That's all we said. You can recognize that people continue to use biomass, continue to use LPG, and everything is mixed. You cannot get exclusive LPG use when you just give the cylinder and say use it. Then we said, okay, we will give you some conditional transfer. You use it, we will give you more conditional subsidies. You can see that the blue bar and the red bar are trying to move towards each other, but the green bar continues to be high, which means that people are continuing to use the traditional chula without they are not abandoning the traditional chula use. But when you give free fuel, in the last bar you can recognize, once we give free fuel, everybody who was using any LPG is using the LPG exclusively, which sort of proves the point that all our communities, this is a myth to think that rural women don't like cooking with LPG, the food won't taste very good with LPG, and therefore they would like to, really rely on biomass. All this is a fallacy. It is the economic barrier that is preventing most of the populations from transitioning exclusively into LPG use. And therefore we have now mounted a multi-country longitudinal household air pollution and stove use study across 4 countries, in which Ramachandra University is also a part, in Rwanda, in Peru, Guatemala, and India, where we have provided LPG to pregnant women, and we are monitoring birth weight, child severe pneumonia, child linear growth, as well as adult blood pressure in the homes that receive the intervention compared to the homes that have not received the intervention. And we have the first phase results, wherein you can look at what is the control exposures throughout the study period that we have monitored, and what is the intervention exposures. The intervention group received free LPG throughout the intervention period, and therefore we have now established that if you provided free LPG, you can actually get below the WHO interim target guideline, which is illustrated by the dotted line, for a good 18-month period. Will this result in health benefits? Is something that we are waiting to find out. We are analyzing the health results, and therefore we'll be happy to share when the health results become available. So last 2 slides I want to conclude with is addressing, what is the way forward? What can we do to think about, what can pollution control boards think when they talk about air quality management? One suggestion that I would like to implore, Dr. Tyagi is attending the session, Dr. Shiva and many other senior colleagues are there. One of the things to address is addressing seamlessness. Let us not be compartmentalized when we look at air quality management. We want to do air quality management. Let us look at the limits of the geographical boundaries that we have to sort of really target. Just doing it in one district is not going to benefit. Just doing it in one city is not going to benefit, because invariably there will be contamination from the other sources. We have to look at where are the the basic the sheds, the air pollution sheds. It has to be an air pollution shed based approach, not a sector or not a district or a city boundary, because air pollution does not recognize political or administrative boundaries. The other important factor to recognize is that just by intervening on air pollution, you may not be able to sort of overpower the influence of nutrition, schooling, other drinking water, electricity, or housing. It would be very naive for us to think that just because we intervene on air pollution, we will see the health effects miraculously. So the interventions will not provide you ready-made answers. We have to intervene holistically. This is why we have to be sort of looking at strengthening synergies in the current policy landscape. We have to look at many ongoing programs, and the government currently has many programs that is already targeting a unified approach. PMUY, Swachh Bharat, Mission Indradhanush are already one set of programs that we can move towards for the rural population. Similarly, it may be possible to bring many synergies in the current policy landscape for holistic approaches to reduce health burden. Air pollution is a big burden, and therefore there are no simple solutions. We have to sort of really rally around and mobilize an army, and I'm so happy to be part of building capacities for these agents of change. For true impact on the ground, there needs to be a healthy dialogue between those who create information, who create the research evidence like us, those of you who are responsible for distributing it, and the decision makers who may be in attendance today. So we have to sort of move from just networking between each other, to working long-term collaborations. So thank you, Dr. Shiva, for giving us this opportunity to share our paradigm for creating seamless, healthy breathing spaces. And I bring greetings from my entire team. Dr. Shiva will remember the day when I was a sole member of this EHE team. We have known each other over the last 30 years, almost 25 years plus. And now we are proud to host multiple educational programs, as well as, so this is the entire team, over 100 strong in various parts of India, that are currently engaging to contribute to this research evidence. Truly appreciate this opportunity. It has been a delightful opportunity to share all our experiences. I hope it was useful. Thank you.
Professor Kalpana, thank you very much for the wonderful talk, and it's very inspirational and very thought-provoking for all the young minds to focus on air pollution and health-related studies. And before we take up some questions, I thought it's a good time to give some break for you, and use that time for. Could you please all start your camera? We'll have one picture with the speaker, and then we'll use it for as a memory for the today's lecture. Swaroop, are you taking the picture? And
yes, sir. I'm
just to arrange them properly, and then please take the picture.
Yes, sir. I can.
Yeah, thank you very much. Kalpana, it was a mind-blowing, talk to give various aspects which you covered. Although your vast experience is something which nobody can, match with that. So I have a couple of questions too, and in fact, I'll be appreciation from the heart to see that you are an inspiration for all the women, particularly the younger students who are pursuing research in the area of, air pollution or other fields, and probably you are kind of a role model for them to see that how they can focus in their studies to, achieve greater heights and keep you as a, role model in their career. So to have a couple of questions which is coming quickly on linking to some of the things which based on your experience, probably you should give some insight into that so that it will also help because several policy makers also attending this talk. Yeah. So the one of the thing is this the air pollution standards. Different countries have different standards, and also the associated health risks are quite different. Do you think that these air quality standards, for example, India is planning to revise air quality standards, and now we have a lot of evidence on health risk aspects. So do you think that whether these standards comparing to the developed countries and associated health risks, what they have understood, and then how do we see that whether the standards, whatever we are thinking to revise, are they sufficient? Are they we need to be look at it, changing it with respect to the new evidence?
Yeah, that is a what do you call a very big dilemma for many of us who sort of process the evidence and sort of really look at should countries be moving towards revising their standards based on the new and emerging evidence of health effects at lower and lower exposures. My own personal take on this is that the WHO interim target guidelines that we developed almost 15 years ago, 2006, were precisely meant to address this. We recognize that countries, it may not be feasible to immediately achieve total health protection, but can we achieve at least health improvement for most of the masses, as the case may be, without sort of posing an insurmountable regulatory burden. So it's not enough if you just revise the air quality standards. If you revise it to 20 from 40, one stroke, but what is the cost of actually monitoring that? There is a huge burden associated with actually implementing the particular policy. So right now, we do have the interim target guidelines, and given that our national ambient air quality standards is very close. In fact, last time when we revised the PM 2.5 standard, the WHO interim target guidelines was very much in the mind, and that's why we chose a number of 40 micrograms per meter cube for PM 2.5. I personally would not advocate putting more energy into revising the national ambient air quality standard downwards, but to achieving greater compliance throughout the country, and to sort of look like where have we achieved. For example, if Tamil Nadu, we have achieved a PM 2.5 compliance throughout the state. Can we look at benchmarking Tamil Nadu as the first state? Every district we are achieving national ambient air quality guidelines for all the criteria pollutants, not just PM 2.5. We don't have much ozone, data to sort of really look at. And then can we look at other states, emulating Tamil Nadu to look at emissions control or other air quality management is not just about emissions control, right? There is a whole lot of plans that are required. Can we look at emulating? Can we look at those resources being apportioned to managing as a country? Like I said, air pollution is not going to go away in India because it has gone away in Tamil Nadu. The burden is going to be high. We need to be attacking the entire country with this. So instead of more regulatory burden, and that's why guideline values are guideline values, and each country sort of chooses to revise its standard based on many other technical feasibility. It is not based on just health evidence alone. What was the biggest difference between the last time revision and this time revision is that health evidence from India corroborates health evidence from other parts of the world. So we don't have to wait for more health evidence. Let us just try to look at moving towards air quality standards that we already have in place throughout the country. Which sources? Household sources is certainly one of the very large sources, but that may not be entirely enough. But we can start with one, and have a discussion on which sources will help us get there and how so.
Thank you, Professor Kalpana. I think it was very useful to understand that compliance is required in terms of control at the source rather than going because changing frequently the standards. I completely agree with that one. The next question is again with the standard. As CPCB has recently announced a revision of National Ambient Air Quality Standards. What is your opinion establishing health-based standards based on WHO interim targets, particularly focusing towards PM 2.5 concentrations?
Again, I have already, answered this question in terms of, which interim target guideline would we go to? Right now, if you want to look at the guideline value, is 5 micrograms per meter cube of PM 2.5. Even the developed countries are not able to move towards that. Can we, we could benchmark ourselves, against an interim target guideline, 2, for example, which take us further down the path. To do that, if that's something that we want to aspire, and we could look at the health benefit calculations because we do have the exposure response information. Like we can actually look at if you are in this part of the curve versus this part of the curve, what would be the net gains by revision of the ambient air quality standards. And I would say the cost benefit has to be looking at monitoring compliance versus the health benefits. So if the annual average for the country right now, population weighted exposures, annual average PM 2.5 is upwards of 60 micrograms per meter cube. If we can look at strategies for the entire country to be at 35 micrograms per meter cube, which would be ITG 1 of WHO, what would be the cost? Compare that to the cost of revising the standard and complying with the new standard. This is a researcher perspective. I am not a policy maker. So the research evidence tells me that we are going to be needing to protect public health if it is a health-based metric, and we are going to be needing to intervene simultaneously on multiple other risk factors. Air pollution is playing on the underlying prevalence of non-communicable diseases. We have to reduce the overall prevalence of diabetes, reduce the overall prevalence of cardiovascular disease. Air pollution may be low. If diabetes is high, air pollution attributable burden for diabetes will be high. So there are multiple factors. So we have to look at according resources for all the risk factors that are affecting the same health condition as air pollution. So we have to be very mindful of recommending a revision in the standard, adding the cost, without being mindful. At the same time, being a public health person, I would be the first person to have a lower standard, but we have to be looking at multi-factor risk reduction if we have to achieve the public health benefits that we are needing to achieve.
This is one interesting question related to the interesting data which your study has showed it. The geographically, the air pollution concentrations changes and exposure, and also the kind of the activities that happens in the rural area and related health risks. So in that context, do you think that the sources in terms of the different types of fuels they may be using, whether the kind of woods they are using it for their cooking, and also the local environmental parameters, do you think that they also play a significant role in terms of their exposure related health risk?
Of course. Yeah. So, I didn't break it down altogether. So nationally, if you want to pinpoint one source throughout the country, it doesn't mean, intervening on LPG in Tamil Nadu will have the same benefits as intervening on LPG for Uttaranchal or Chhattisgarh for that matter, because there are other sources which have to be attacked simultaneously, and LPG may have already been addressed in Tamil Nadu, for example. So there is a much more detailed breakdown available at the state level for individual, source apportioned, health risks that are available that needs to be examined at the state level for state level priorities. So obviously the benefit, but if you look at one source, lowest hanging fruit is all I'm talking about. One source, one sweep, if we can sort of tackle that, it would have more than air pollution related benefits. That's what I'm trying to say. Time poverty, quality of life, many other energy equity issues, climate, short-term climate, all the short-term, short-lived climate pollutants, black carbon, all, SLCPs, emissions from cook stoves, very much argue in favor of transitioning to cleaner energies. So if we can actually leapfrog into renewable-based cleaner household energy, nothing like it, but at least at the interim, fossil fuel-based clean energy would be a near-term health benefit for many populations.
Thank you very much. I think this is a clear message. At least we should look for low-hanging fruits in order to at least quickly to get some health benefits. Yeah, there is some interesting things which you already mentioned during your talk. See, for example, when we are trying to ask the rural women, why are you not using LPG, although the government has provided, their first thing they said, no, the taste is was something which they don't want to compromise, and that's why they are using the LPG. But then when we start, going little deeper and start discussing, bringing some confidence and other things, then they will discuss that some, as you rightly mentioned, the economical cost is one
Yes.
aspect. The other one is the LPG, if it is over, immediately getting the next cylinder will take some amount of time. These are the two things which we have just indicated to us when we are exploring. Do you think that are there any other factor also influencing as kind of a fear or something which they were experimenting with LPG?
Right. Very good question. In fact, this is a myth that I am now totally convinced that is absolutely a myth, because we have now worked in more than 8 states. What you said is exactly right. On the surface, they will say something about the men in my family don't like the roti that is made, especially in the north. They will not like the roti that is made in the LPG stove. They want the tawa cooked roti. Nothing. You give them LPG free, they just lap it up. They just, everybody loves the convenience, loves the efficiency, loves the, and even the women in the, decision making power, of course, is a very difficult, thing to address in some districts and some geopolitical contexts. But if you look at individual preferences, this whole preference just boils down to one thing: economic barrier. If you give LPG free, you don't have to do anything. That's what we found in the Happen trial. 18 months, people said you should do videos in order to make them use LPG and not use, what we said was, this is something we want to prove, that LPG is beneficial for you to health, but we can only have a half a chance of doing that if you use LPG continuously. So we are going to give you LPG as long as you do not, use it's more important not to use the traditional stove, right? What's the point in using both? We didn't do any kind of reinforcement. All we did was provide free LPG. This was in the most backward districts of Tamilnadu, okay, where the literacy level was very, very low. The community force was very, very strong to make women do whatever the decision makers in the family want. We didn't have to do anything. Compliance was universal because as long as it was not taxing the pocket of the family, LPG compliance was 100%. So the economic barrier is what we have to find ways. Somebody, I think in the chat also asked the question, how do we find the money to provide free LPG? Can we look at putting this in the development assistance, just like free drinking water? How many people, if you want rural villages to buy bottled drinking water, it's not possible. We have to provide them clean drinking water. Similarly, clean fuel would be the next in the agenda of development assistance, not any other means. Just like vaccination, true cost of vaccination is so low, vaccines are being provided free. It is the same public health measure. It has to be provided as part of the overall health sector assistance, overall public health assistance. There is no way we can wait for these people to get rich enough to afford LPG.
Yeah, thank you. So this is another interesting question from a young researcher. For the health risk assessment, there will be some mathematical models being used and some relationship has been established.
Yes.
And most of this data always comes from some of the studies they focused in developed countries. And when we are adapting those procedure and approaches to some of the developing countries where economics plays an important role, and their exposure duration, the exposure activities. So what is your suggestion on this? Should we have our indigenous? I'm sure that you have already might have been some couple of such things. So what is your suggestion on this kind of an studies?
Okay, so I like to use this paradigm. This framing of a paradigm based on one of my very early mentors, Professor Kirk Smith in University of California, Berkeley. Absence of evidence is not evidence of absence. We don't have all the exposure response information based on our own country studies, but it does not mean that we that particular association does not exist, because we have every indication that the available evidence is in no way in contradiction to the evidence available globally. What is missing is the evidence globally that is used in these global burden of disease models is based on chronic disease outcomes and long term exposure based studies, which so far we have not been able to mount very successfully. So the types of studies that we have done in country are slightly different based on the availability of the health data, based on the availability of the exposure data. It is only a matter of another 3-4 years before we are able, because now the capacities in country for conducting such research has come of age. Now we should be able to, now satellite based data, we can go back 20 years, 25 years, and we have ground truth data to validate the satellite data, and we all these measures are available. So right now, especially if you're a young researcher asking this question, let me clear this doubt totally. There is no evidence that currently makes us think that the relationship between exposure and outcome is different for the developed countries versus the developing countries. And we now have evidence across the exposure spectrum, all the way from 5 micrograms per meter cube or even 1 microgram per meter cube of PM2.5 annual average to 150 micrograms for PM2.5. Every study may not be available in India. There are studies in China, there are studies in other parts of South Asia, including some studies in India for some of the outcomes. Not every outcome, not every exposure is addressed in, but the global pool of evidence is consistent throughout the world. And therefore, public health precautionary approach demands that we have to act in order to provide the benefit to those communities that are needing that. You may want to argue about coming down to 5 or 10, but there is nowhere where the evidence to stay beyond the national ambient air quality standards. There is no evidence to support that. We have to comply with our current standard everywhere, all the time.
Thank you, Professor Kalpana. This is my last question, because there are so many questions are still coming up, but we will, in the interest of time, and I know your other commitments, we'll going to close this with this last question. I like this question. See that air pollution has no boundaries, but the administrative standards will have all boundaries. How do we look at it in terms of addressing this issue? Because do you also see that whether we should have a networking of different countries, different states, and different geographical regions in terms of framing this policies on air quality standards?
Fantastic question, and can't agree more. We have to have this dialogue across people who are part of an airshed, because you will get we will one of us who are at the receiving end will get all the burden. What people, just like people like I mentioned in that slide, right? When for water pollution it's a different matter, for air pollution it's a different matter. So we want to if you're looking at somebody at the source, but that source is actually not impacting the the local populations, but in turn, because of the geography is getting transported, sometimes it might be even inter-country collaboration that may be required, especially in the Indo-Gangetic plain. It will definitely be required, but at least within the country we have to look at getting the act together in concert. And therefore, this dialogue across states is very much essential to sort of really look at which airshed. We now have very good dispersion models to sort of really map out the airshed, and we have mapped out these airsheds. So sources within an airshed must be controlled collectively by the combined administrations of those geographical boundaries. So therefore, that's the way to move forward. To move it piecemeal is not the solution.
So Kalpana, thank you very much for this wonderful and excellent talk. And we are really benefited from your experience, sharing vast ideas and various studies which you have carried out not only in India, across the globe. So now I'll request Ashwin to summarize the talk and yeah.
Very good afternoon to everyone. First of all, I would like to thank Professor Kalpana for giving such an insightful lecture. To summarize the talk, she started with where India stands with respect to air quality guidelines. She also touched upon the state level exposure and how reliance on solid fuels contributed to household air pollution. And she highlighted how 2 years of life expectancy is lost in India and how very little gains have been achieved in reducing rural and urban pollution. Professor also gave an interesting insight on how intervention in air pollution can yield better results compared to tobacco. This was based upon the number of people exposed compared to the tobacco. She then moved on to the advancements in personal exposure assessments and how technologies have been advanced to capture exposure heterogeneity in rural and urban areas. She also shared her experience through various case studies of cohort studies like cardiovascular health effects and maternal health effects of cohorts consisting more than 3,000 participants. And more interestingly, the studies also used PM 2.5 measurements from various sources like satellite-based PM measurements, land use-based PM measurements, ambient air quality measurements, and personal exposure measurements. She also touched upon the air quality actions like reducing household pollution through interventions like free LPG and conditional cash transfer. And finally, the professor concluded with two major suggestions like using airshed-based approach for achieving seamlessness throughout the country and strengthening the synergies through holistic intervention and not just concentrating on air pollution. So with these major insights, I'm sure the participants were introduced to some very interesting ideas and research problems that they can carry out in their coming future. I hope this lecture was very helpful to all the participants. And I would like to thank Air Quality Management Association and the CEPHA network for arranging this talk, and our student volunteers for organizing this lecture, and Professor Shiva for organizing this IQML series. And once again, I thank Professor Kalpana for such an interesting and wonderful talk. Thank you, ma'am.
Yeah. Thank you very much, madam. And
Okay.
thank you all the participants for joining us.
Thank you. Yeah, thank you.
Thank you.
Yeah. Bye.
Bye.
Yeah, it's